platelet disorders. So there is the two topics that we will discuss today are ITP and hemophilia. First of all, some points regarding ITP and platelets. So platelet is derived from megakaryocytes. Platelets are nucleated or non-nucleated? Non-nucleated fragments of megakaryocytes, and these are produced in bone marrow. Janis to egulo? Megakaryocytes are large polypoidal cells, and it that shedding of platelet occurs through budding of cytoplasm, and platelets are liberated into the circulation. Egulo tora janis, megakaryopoiesis. Now, one factor is called thrombopoietin, which I will discuss later on my lecture, that this thrombopoietin is a primary growth factor that controls production of platelets. So, if we can induce thrombopoietin production, then by that we can increase the production of platelets. So, normal platelet count koto? Normal platelet count koto? What is the normal platelet count? 1.5 to 4 lakhs. Less than 1.5, we call it thrombocytopenia. So, in thrombocytopenia, there are various causes. This is some of the causes of thrombocytopenia. First of all, most common cause of idiopathic thrombocytopenia is ITP, immune thrombocytopenic purpura, or idiopathic thrombocytopenic purpura. Next cause is infections. Among infections, most common and most deadly nowadays in rainy season is ki? Kothay platelet count kom dekha jay? Dengue. Kise platelet er sobtheke beshi patient expire kore is dengue hemorrhagic fever. Other causes are like DIC or disseminated intravascular coagulation, torch infection, and HLH syndrome, hemophagocytic lymphohistiocytosis, HLH syndrome. Some medications also decrease the count of platelet like valproate, heparin, some penicillin group of drugs. One disease is called thrombocytopenic purpura, and another is called HUSH or hemolytic uremic syndrome. These are microangiopathies that can cause thrombocytopenia. Malignancies like leukemia, lymphoma, patient presents with patency, purpura and bleeding. Autoimmune disorders like SLE, systemic lupus erythematosus. One disease is called Evans syndrome, autoimmune hemolytic anemia with thrombocytopenia. Another is called APLA or antiphospholipid syndrome. Another is called neonatal alloimmune thrombocytopenia. Baby born with thrombocytopenia and presents with bleeding manifestations. Generally, presentation occurs within first week of life. Other immunodeficiency diseases like HIV and Wiskott-Aldrich syndrome, bone marrow failure disease like TAR, thrombocytopenia absent redi, TAR syndrome, Fanconi anemia and Shwachman-Diamond syndrome. Other causes are hypersplenism. Spleen is the destruction site of the platelets. Like hemolytic anemias, spleen is the destructive site of platelets and RBCs. So, hypersplenism is a cause of thrombocytopenia. Another disease is called Kasabach-Merritt syndrome. What is Kasabach-Merritt syndrome? It is a type of vascular consumptive coagulopathy. Patient একটা vascular tumor, তার সাথে bleeding manifestations with coagulation thrombocytopenia নিয়ে present করে. It's called Kasabach-Merritt syndrome. Next, there are other causes like qualitative disorders of platelet function. এতক্ষণ যেগুলো বললাম সেগুলো হচ্ছে কোয়ান্টিটেটিভ। কোয়ালিটেটিভ ডিসঅর্ডার কি কি হতে পারে? One is called বার্নার্ড সোলিয়ার সিনড্রোম, GP1B ডেফিসিয়েন্সি, এটা তোদের MCQ তে আছে। গ্ল্যান্সম্যানস থ্রম্বাসথেনিয়া, GP2B3A ডেফিসিয়েন্সি, অ্যানাদার ইজ কল্ড গ্রে প্লেটলেট সিনড্রোম। এগুলো শুধু নামগুলোই জান তাতেই হবে। অ্যাকোয়ার্ড ডিসঅর্ডারস লাইক CKD and cardiopulmonary bypass. These are the platelet disorders. There are some coagulation disorders. By that, patient can also come with bleeding manifestations like hemophilia A and hemophilia B. Von Willebrand disease, you all know that what is von Willebrand disease, and other causes like liver disease, vitamin K deficiency and warfarin overdose. DIC can also cause consumptive coagulopathy and bleeding manifestation. Now এই জিনিসটা এই চারটা মনে রাখতে হবে যে what are the differences between what are the clinical features that are different in bleeding disorder and coagulation disorder. Bleeding disorder মানে কি আমরা ITP, coagulation disorder meaning hemophilia. Bleeding disorder, site of the bleedings are skin and mucous membrane, and Pathogenesis purpura will be present in bleeding disorder. Ecchymosis may be small or superficial. Hemarthrosis is rare. But in clotting factor deficiencies, the site of bleeding are soft tissues, muscles and joints. Pathogenesis purpura are absent in clotting factor deficiency. Ecchymosis and hemarthrosis are the main features of clotting factor deficiencies. Bleeding after trauma or surgery are delayed in clotting factor deficiencies but are immediate in platelet disorders or hemostatic defect. বোঝা যাচ্ছে এইটার এক্সাম্পল হচ্ছে ITP, এইটার এক্সাম্পল ইজ হিমোফিলিয়া। নাও কাম টু দিস চার্ট। এই চার্টটা তোরা ছোটবেলা থেকে বহুবার পড়েছিস, আমি আর রিপিট করব না। ওয়ান ইজ কল্ড ইন্ট্রিনসিক পাথওয়ে, অ্যানাদার ইজ কল্ড এক্সট্রিনসিক পাথওয়ে। টু ডিটেক্ট problem in intrinsic pathway we do APTT. To detect problem in extrinsic pathway we do PT. So all the factors, factor 8, factor 9, factor 10, that are 10 is common pathway, factor 8, 9, 12, 11 are affected in intrinsic pathway disorders. Extrinsic pathway disorders, factor 7. Prothrombin is a common pathway defect. Now see this chart. If the patient comes with bleeding, that means the bleeding is occurring and you have to see whether the patient is having thrombocytopenic or not. If thrombocytopenia is present, then what are the causes you will suspect? First, infections means dengue or some viruses, torch infections and many other viruses do cause thrombocytopenia. Hypersplenism, যেটা এক্ষুনি বললাম, immune thrombocytopenia most common, thrombotic microangiopathic, malignancy, Fanconi anemia and TAR syndrome, thrombocytopenia with absent radius. If the platelet count is normal, then you have to do PT and APTT. If both PT and APTT are deranged, then what you are thinking is the defect in common pathway. Defect in common pathway occurs in liver dysfunction, vitamin K deficiency, DIC and use of oral anticoagulants. If the PT is abnormal and APTT is normal, then the problem is in extrinsic pathway, factor 7 deficiency. If the problem is in APTT is abnormal and PT is normal, then you should suspect hemophilia A, B or von Willebrand disease. বোঝা গেল? এই চারটা ইম্পর্টেন্ট তোদের এক্সামের জন্য। Approach to a bleeding disorder or approach to a bleeding child. Now coming to today's topic is the idiopathic or immune thrombocytopenic purpura. First আগে নাম ছিল, previously it was named as immune thrombocytopenic purpura. Now it has been called as idiopathic thrombocytopenic purpura. তোরা যে কোনো একটা নাম বলতে পারিস, both are similar. It is the commonest bleeding disorder in children. Usual age of presentation is 1 to 7 years. acute ITP lasts less than 6 months. Acute ITP are of two types. One is acute ITP and another is chronic ITP. Most common is acute ITP. Acute ITP usually lasts less than 6 months. Coming to the pathogenesis. First of all, the exact pathogenesis is undetermined most of the cases. But in chronic ITP, many patients demonstrate antibodies against alpha 2b, beta 3 and GP1b. GP1b किसे छिलो? बार्नार्ड सोलियर है. Alpha 2b, beta 3 এটা MCQ তে আছে তোদের. In chronic ITP, the antibodies are formed against alpha 2b, beta 3 and GP1b. After binding of the antibodies to the platelet surface, circulating antibody coated platelets are recognized by the FC receptors on splenic macrophages and they are destroyed. মানে site of destruction of platelets is spleen. Now there are some also viral associations of ITP. What are those viruses? These also comes as an MCQ. Epstein-Barr virus, HIV, MMR vaccine, COVID vaccine, infection associated with H. pylori and HIV. These HIV, H. pylori commonly in chronic ITP, these are the causes, associations. There are other associations in chronic ITP, সেটা পরে আসছি. Now how do patients manifest? কিছু বলতে পারবি ITP patient কেমন আসে, কিভাবে আসে, what are the common complaints? বলতে পারবি কেউ? এক্ষুনি বললাম ব্লিডিং ডিসঅর্ডার হলে কি থাকবে? হ্যাঁ বল, কি থাকতে পারে? পেটাচি, পারপিউরা নরমাল and increased number of megakaryocytes. কি রকম দেখতে লাগবে? Now this is the peripheral blood smear picture, this is bone marrow picture. Peripheral blood smear picture e eglo ki? This is RBCs and this is the platelet. Look at the size of the platelet. The size of the platelet is very large. Eta ekta platelet, but this platelet is very large. So large size platelet is a characteristic of ITP. Now see the bone marrow picture. Bone marrow picture, there are plenty of cells. These are bone marrow fat cells. এই সাদা সাদা গুলো, these are bone marrow fat cells. These are megakaryocytes. এই cell, these cells, these cells, these cells. These are megakaryocytes. So there is increased number of megakaryocytes and the size of the megakaryocytes also do increase. Generally, we do not do bone marrow examination in ITP, but if you do this, then you will get this picture. So indication of bone marrow aspiration biopsy include an abnormal WBC count or differential or unexplained anemia, meaning if you are suspecting leukemia or lymphoma, then only you can do bone marrow. Another examination is done is DCT or direct Coombs test, because one association is called Evans syndrome, autoimmune hemolytic anemia associated with thrombocytopenia. In Evans syndrome, the DCT will be positive as it is a autoimmune disease. Now coming to the management. First management is wait and watch. If there is no symptoms, no other problem is present, then you can do wait and watch. If the child is getting any drug which decreases platelet count, stop this drug like aspirin. Platelet transfusion is only given if there is history of severe hemorrhage and the platelet count is less than 20,000. যদি 20,000 এর উপরে থাকে আর only minor purpura থাকে, then there is no need to give platelet transfusion, because if you give platelet transfusion in a child with no bleeding manifestations with a platelet count of 50,000, 40,000, the platelet you are giving will be also distracted by the same immunological phenomenon দ্যাট ইজ দ্য প্রাইমারি কজ অফ দ্য ডিজিজ। যত প্লেটলেট দিবি সেটা আলটিমেটলি ডেস্ট্রয় হয়ে যাবে, কারণ সেম ইমিউনোলজিক্যাল ফেনোমেননটা সেই প্লেটলেটকেও ডেস্ট্রয় করবে। কাজেই ইফ দেয়ার ইজ নো লাইফ থ্রেটনিং ব্লিডিং অর প্লেটলেট কাউন্ট ইজ মোর দেন 20,000, প্লেটলেট দেওয়ার কোনো দরকার নেই। সেম জিনিসটা ডেঙ্গুতেও অ্যাপ্লিকেবল। So what are the treatments can be done? First of all, it is an immunological disease, so the first drug of choice will be corticosteroids to suppress the immunological phenomena. Another is called antivenous IVIG, intravenous immunoglobulin, and anti-D antibody can also be given. Corticosteroid, how corticosteroid is given? It causes both inhibition of phagocytosis and antibody production. It also causes improved platelet production and microvascular endothelial stability. 2 to 3 drugs are used. Just you have to remember the name of the drugs. One is prednisolone, another is methylprednisolone, another is dexamethasone. Mostly এই তিনটে ড্রাগই ইউজ করা হয়, এর বাইরে কোনো স্টেরয়েড ইউজ করা হয় না। জাস্ট রিমেম্বার these 3 names: methylpred, prednisolone and dexamethasone. Coming to intravenous immunoglobulin or IVIG. What IVIG does is the clearance of antibody coated blood cells from the circulation by inhibiting the phagocytic activity of the reticuloendothelial system. Dose is 2 gram per kg. No need to remember. That is divided over 2 to 5 days. The main problem of IVIG is its cost. It's very expensive. 1 5 gram of IVIG comes at around 10 gram of IVIG comes at around 15 to 20,000 rupees. Side effects are flu-like symptoms, aseptic meningitis, anaphylaxis, and hemolytic anemia. So first line we do not use IVIG. Now another therapy is called anti-D immunoglobulin. Anti-D তোরা আরেকটা ডিজিজে দিয়েছিস গাইনিতে, কোথায় বল? anti-D কোথায় দিয়েছিস? anti-D গাইনিতে তোরা পড়েছিস, কোথায় ইউজ করেছিস? Yes, hemolytic disease of newborn. সেখানে যে anti-D দিয়েছিস সেম anti-D. It is a plasma derived immunoglobulin prepared from donors selected from a high titer of Rh antibody that is used only in Rh positive patients. Generally আমরা first line হিসেবে anti-D ইউজ করি না। Therapeutic effects last for 1 to 5 weeks and side effects are very few. Same anti-D যেটা তোরা গাইনিতে ইউজ করেছিস এখানেও সেটা ইউজ করা হয়, বাট নট অ্যাজ এ ফার্স্ট লাইন থেরাপি। These are the treatment options of ITP. What are the treatment options? Number 1, you can, if there is no other symptoms present, the patient is only presenting with Platelet Purpura, you can go for observation. Another is corticosteroid. I have already said that. Advantage is it is inexpensive. Disadvantage is side effects of corticosteroids. IVIG, advantage is advantage is its rapid action. Disadvantage is expensive. Now coming to this thing, rituximab. Do you know what is rituximab? কেউ জানিস? Anti-CD20 antibodies, rarely used because it is very expensive. Another is splenectomy. Splenectomy is rarely done only in refractory ITP or chronic ITP patients. Splenectomy, spleen is the destruction site of the platelets. So if splenectomy done, the rate of the destruction decreases. So splenectomy is an option. But there is chances of lifelong infection. Now coming to these things, thrombopoietin receptor agonists. So thrombopoietin do stimulate the production of platelets. That's why thrombopoietin receptors agonist can be used. হ্যালো, বলছি আপনাকে ঘন্টাখানেক পরে ফোন করছি। So thrombopoietin receptor agonist can be used. What are the thrombopoietin receptors agonists? সেটা আমরা পরে আসছি। So thrombopoietin receptor agonists, these are very expensive. Problem is that these are very expensive. Splenectomy can be done in children with ITP for more than 1 year. Now coming to the chronic ITP. In chronic ITP আমরা কাকে বলবো? If ITP have persisted for more than 12 months, then it is called chronic ITP. There are some associations of chronic ITP. That means there are various diseases that are associated with chronic ITPs. If you are stamping a patient with chronic ITP, first you have to rule out these diseases before saying that the patient is having ITP. Like SLE, এটা আগেও বলেছি, SLE is a cause of thrombocytopenia. So SLE, HIV can cause chronic ITP. It can also cause acute ITP. Type 2B or platelet type von Willebrand disease, X-linked thrombocytopenia, autoimmune lymphoproliferative syndrome, CVID or common variable immunodeficiency syndrome, and autosomal macrothrombocytopenia. These are associations of chronic ITP. So before stamping a patient with chronic ITP, you have to rule out these diseases. Presentation is similar to acute ITP, and WAS is Wiskott-Aldrich syndrome. So what are the treatment of chronic ITP? Splenectomy, as I have said previously, you can do splenectomy. The first line therapies are similar to acute ITP, like steroids, IVIG, anti-D. Second line therapies are, just remember the names: danazole, vinca-alkaloids, vincristines, azathioprine, cyclosporine, and cyclophosphamide. Just remember the names. Now, two effective agents. These are thrombopoietin agonists. One is called romiflostim and another is called L-trombopag. Remember the names. These are approved to treat adults and children with only chronic ITP. They increase the platelet count and they compensate for the increased destruction of the platelet to maintain the platelet count of more than 50,000. মোটামুটি থ্রম্বোসাইট এরা প্লেটলেট কাউন্ট নর্মাল করে না, বাট 50,000 এর উপরে মেনটেন করতে হেল্প করে, so that the life threatening hemorrhages do not occur. Now coming to the second topic of our discussion is called hemophilia. Hemophilia কি হয় বল, কেউ বলতে পারবি what is hemophilia? জানিস তোরা? বল, hemophilia কোন ফ্যাক্টর ডেফিসিয়েন্সিতে হয়? ফ্যাক্টর 9. ফ্যাক্টর 9 হলে আমরা কি হিমোফিলিয়া বলবো? B, and 8 হলে A. So hemophilia is a which genetically it is which linked disorder, X-linked or autosomal? Hemophilia কি X-linked or autosomal? X-linked. So the predominantly males will be affected. Hemophilia A is due to factor 8 deficiency. Hemophilia B is due to factor 9 deficiency. And these are the most common coagulation congenital factor deficiencies. Coming to the genetics, as you have said, it is a X-linked disorder. So genes for synthesizing these factors will be present on X chromosome. Gene for factor 8 and 9 are carried by the terminus of long arm of X chromosome, making hemophilia an X-linked disorder. But 1/3 of the cases are estimated to be results of a spontaneous pathogenic variant. That meaning তার কোনো ফ্যামিলি হিস্ট্রি থাকবে না। মোস্ট অফ দ্য হিমোফিলিয়া পেশেন্টের ফ্যামিলি হিস্ট্রি থাকবে, বাট 1/3 of the patient may not have family history. some female carriers have sufficiently low factor level to have abnormal bleeding. ফিমেলরা কি হয় এক্স লিঙ্ক ডিসঅর্ডারে ক্যারিয়ার, বাট very few female carriers do present with abnormal bleeding, heterozygotes. Female carriers with factor levels of less than 40% are considered to have hemophilia and should be treated as such. Now, what is the clinical manifestations of hemophilia? How do patients present with hemophilia? Hemophilia patient কি নিয়ে আসে? কেউ বল, how do patients present in hemophilia? কিভাবে আসে? In severe hemophilia, আচ্ছা প্রথমত mild, moderate, severe, we can divide the hemophilia into 3 types. In severe hemophilia, the factor activity is less than 1%, both factor 8 and factor 9, যেটা হোক। Patients with severe hemophilia, bleeding is frequent and spontaneous. In patients with moderate hemophilia, factor levels of 1 to 5% normal and bleed excessively with mild trauma. যদি moderate hemophilia হয়, then factor levels will be 1 to 5%. মানে severe hemophilia হলে factor less than 1%, moderate hemophilia হলে factor 1 to 5%. Individuals with mild hemophilia have factor levels of 5 to 40%. Are normal. Usually they only bleed abnormally after a major trauma or surgery. আমরা most common কোন patient পাই? Mild hemophilia. Most common is mild hemophilia. Factor level is 5 to 40%. In neonates, factor 8 and factor 9 that does not cross the placenta. So, in neonates may present with intracranial hemorrhages, mostly from birth trauma, vacuum extraction or forceps extraction. তখন intracranial hemorrhage হতে পারে। In the absence of positive family history, hemophilia are usually undiagnosed in the neonatal period. Neonatদের otherwise বোঝা যায় না। But if there is history of easy bruising, intramuscular hematomas, hemarthrosis, that are usually present when the child begins to crawl or creep or walks, যখন ওই জয়েন্ট গুলো হিট করে, কোথাও পড়ে যায়, লাগে, তখন সেখানে হিমাটোমা হয়। So usual age of presentation is not less than 1 year. তার আগে বাচ্চা দাঁড়াতেই পারতো না, চলতেই পারতো না। যখন দাঁড়াতে বা চলতে শিখছে, বাচ্চা ছুটতে গিয়ে হাঁটতে গিয়ে পড়ে যাচ্ছে, that minor trauma can cause deep-seated hematomas in these children. We usually do diagnose at that time. Neonatal age diagnosis খুব rare. In children, the hallmark of hemophilia is hemarthrosis, মানে joint bleeding after minor trauma. The most common joint is affected are knees, ankles and elbows. কারণ কি ওই দিক দিয়ে ওরা ক্রল করতে চেষ্টা করে আর ওখানে সবথেকে বেশি হিট করে। So knees, ankles and elbows are affected. Repeated bleeding episodes into the same joint results in a target joint. Target joint means দেখা যাচ্ছে ওই বাচ্চার ক্ষেত্রে প্রত্যেকবার পড়ে যাওয়ার সময় ওই জয়েন্টেই অ্যাফেক্টেড হচ্ছে। দ্যাটস ওয়াই দ্য পেশেন্ট ইজ হ্যাভিং repeated hematoma or hemarthrosis in the same joint. It is called target joint. Now another problematic situation is called muscular hematomas. Muscular hematomas meaning in muscular hematomas the hematoma will present inside the muscle fascia. That's why it is usually not very prominent. One of the muscles is called iliopsoas tendon, iliacus and psoas major. In iliopsoas major আমাদের কোন মুভমেন্টে হেল্প করে? হিপ জয়েন্টের flexion and internal rotation. So if there is hematoma into the iliopsoas muscle, then the child will have only vague lower abdominal pain associated with pain when flexing the thigh or internally rotating the thigh. Otherwise, কোনো symptom পাওয়া যাবে না. That iliopsoas hemorrhage is a medical emergency. দেখা গেছে iliopsoas hematoma হলে there is huge bleeding inside the iliopsoas muscles and it may go unnoticed because বাইরে থেকে দেখে বোঝা যায় না. ছবিটা দেখ. This is hemarthrosis. This is the normal leg. This is the hemarthrotic leg. দেখ কতটা সোয়েলিং আর রেডনেস হয়েছে. hemarthrosis. বোঝা গেল? There are some life threatening bleeding. Life threatening bleeding কোথায় কোথায় হতে পারে? Intracranial hemorrhage number 1. Number 2, GI hemorrhage. Patient can present with hematemesis or melena and iliopsoas hemorrhage যেটা এতক্ষণে বললাম. Now look at that picture. দেখা যাচ্ছে পিকচারটা? See, first is the X-ray. Now the patient had iliopsoas hemorrhage in the right side. 50 to 60 international unit per kg, factor 8 on D1 day 1, then 20 international unit per kg on the following day till the joint function comes back to normal. If there is muscle hematoma, then the dose is quite similar, 50 per day in day 1 and 20 every other day. Treatment may be needed until it is resolved. Hemophilia B তে দেখ ডোজটা আরেকটু বেশি লাগছে, almost double, 100 international unit per kg, factor 9 concentrate on day 1, then 40 on following day, just 8 double. Muscle hematoma te around 80 to 90 concentrate and 40 per kg every 2 to 3 days until the hematoma is resolved. There are some prophylactic therapies. It is called some newer prophylactic therapies that are used, but these are not factor 8 or factor 9 concentrate. First one is, you need to remember the name, is emicizumab. It is a monoclonal antibody that can bridge activated factor 9 and factor 10 to restore factor 10 activation. মানে factor 8 আর factor 9 কোথায় লাগতো? factor 10 এ অ্যাক্টিভেট করতে লাগতো, but this factor emicizumab can cause direct factor 10 activation. Number 1. Number 2, look at this drug, efanesocog alpha. This is a modified extended half-life single recombinant factor 8 protein that decouples recombinant factor 8 from endogenous von Willebrand. It is only useful in patients with severe hemophilia A. কারণ এটা factor 8 এর উপর কাজ করে, factor 9 এর উপর কাজ করে না. So efanesocog alpha and emicizumab দুটো নাম পড়লি. Now see this third drug. It is called fitusiran. Fitusiran is a small interfering RNA molecule that reduces the antithrombin synthesis and has been successfully used in hemophilia A or B without inhibitors. Inhibitors কি সেটা আমি পরে আসছি. তাহলে তোদের লেভেলে তিনটে শুধু ড্রাগের নাম মনে রাখবি, emicizumab, fitusiran, efanesocog alpha. Now coming to the complications or chronic complications of hemophilia. One is called chronic arthropathy. একটা তোকে এক্ষুনি বললাম যে জয়েন্ট, একই জয়েন্ট বারবার এফেক্টেড হয়ে কি হয়, that occurs as a target joint. In target joint over chronic time that can cause chronic arthropathy. মানে that synovial membrane got permanently damaged by repeated hemorrhages and that may require joint replacement. This is called chronic arthropathy. Another is inhibitor formation. এবার inhibitor জিনিসটা কি বলি? Now what you are giving is the patient is getting repeated transfusions of factor 8 and factor 9, which is synthesized outside of our body. যখনই সেইটা বারবার তুই দিতে থাকছিস, body will produce antibody against that exogenously administered factor 8 or factor 9. Repeated episode আর huge dose factor 8 factor 9 দিতে থাকলে body will produce antibody against those exogenously administered factors. These are called inhibitors. Inhibitor যদি long time এ formation হয়, then what will happen, that the factors you are giving will be destroyed by that antibodies. So you will need repeatedly high amounts of factor 8 or factor 9 to get that amount of your desired amount of factor 8 or factor 9. মানে আগে যে ডোজে দিলে factor 8 factor 9 কাজ হতো, ইনহিবিটর ফর্মেশন হলে তার থেকে অনেক বেশি ডোজ লাগবে। সো ইট ইজ কল্ড ইনহিবিটর ফর্মেশন। সো ইনহিবিটর যাতে ফর্মেশন না হয়, কাদের ইনহিবিটর ফর্মেশন বেশি হয়? when we give prophylactic repeated dose of factor 8 or factor 9. So to prevent inhibitor formation, we use the drugs that are said, যেটা এইখানে বললাম, these prophylactic therapies. In prophylactic therapies, we nowadays we do not give factor 8 factor 9. We give these drugs to maintain a certain level of factor 8 or factor 9. যখন অ্যাকিউট হ্যামারেজ হচ্ছে, লাইফ থ্রেটনিং হ্যামারেজ, then only you can give those factors exogenously. Otherwise, use these drugs, and use of factor 8 factor 9 are use as low as possible to prevent the formation of inhibitors. বোঝা গেল ইনহিবিটরস কি?